The main reason actually I really wanted to get up here and talk with you guys was mostly to clear my name. Somebody showed me a picture as I was eating lunch this afternoon of me in what appeared to be asleep at the panel discussion yesterday. I was resting my eyes for an extended period of time apparently. So I was not asleep, I was actively engaged in the conversation. So the purpose of this discussion will be a fairly significant gear shift from what we have spoken about the last couple of days. And I would like to talk about the pediatric population. We focused mostly on the morbidity of adult sleep medicine. But what's interesting is that there is lots of similar both pathology and consequences in the child population. And one of the reasons I found myself so interested in that group is because we catch them early on in life, and particularly from the cardiovascular standpoint, there is going to be profound impacts on the developmental and the mortality associated with younger patients if they're not caught early on. Doesn't diminish the need to treat adults later in life, but the earlier it is caught, I think the better the long-term outcomes are going to be. So a little bit about who I am. Dr. Raymond here mentioned most of that. I have no commercial interests. So I got an email at work the other day. I work over at J-Bear Hospital, and the title was BLUF, B-L-U-F. And my first take when I saw that was, did I blow it and F it up all at the same time? I have no idea what could have gone wrong, but the new acronym that we speak of there is the bottom line up front. So what we're going to talk about is going to be, and I think points number 2 and number 3 are what I'm going to focus on the most, and they're contradictory statements, right? It's the importance of the clinical examination, but it's also the major limitations of the clinical examination. Then we'll touch base on the pathophysiology, which I find to be fascinating. And then the main takeaway I think for you guys is going to be the diagnostic criteria, what numbers we use, the recommendations that are made, and how that scoring and interpretation component of a study then correlates into how we change or address our management. So a couple introductory slides here, and the first point is that it's just widely prevalent. So sleep disorders throughout the pediatric population from 0 up until the time they transition to more family or adult medicine is extremely present. There's going to be a rarity in the family who doesn't complain of some problem with their kids. And the reason is because it has impacts in all realms of development, of emotion, of social interaction, and then of course the learning experience these kids have to go through as they start kindergarten, preschool, and then on upwards. And then the people that bring it to our attention is not the kids. It's the patient, it's the parents. And so typically who we are having the conversation with in clinic is going to be the parents and walking them through the diagnostic path essentially. So this is the forest, right? The statement of don't lose sight of the forest for the tree that you're looking at. And I think this is incredibly important. And we've alluded to it several times during the conversation over the last couple of days, but we identify obstructive sleep apnea, or we identify movement disorder or restless leg syndrome, but that in isolation, I think, is rarely the whole body of the problem. And this is not necessarily talking about other comorbid disorders, but it's the other sleep-related things that can impact what the main complaint is. And if we really boil down to what the primary problem is, why do people come to us in the clinic? It's because they want wellness, right? Something bothers them. Something bothers the parent that's related to their child, and they want that problem fixed. And so what we can't forget is if we say take a child that's got mild to moderate obstructive sleep apnea, and we fix it by whichever means we choose to be most appropriate, but the daytime sequela has not gone away. What have we truly done? We can talk about the reduction in mortality and morbidity, the probable improvements we'll get in long-term growth and so on, but the parent comes back to you and says, he's still acting out during the day at school. And I thought these two problems were related. So there is the importance of the entire forest, because especially with the pediatric population, the broadest approach that you can take on your interview, your assessment, and your follow-up is going to provide, without question, the best long-term outcomes. So if you look at this tree, if you, on your left, if we go down to the bottom of the pyramid to the left and then to the middle, That typically is where most of the problems are going to develop, and then they're going to lead to our evaluation. But these all boil down to some form of daytime symptoms, and we'll talk and we'll look at some literature that suggests that the uniqueness of the pediatric presentation is they're not tired. Very rare is it the child who comes to you or the parent comes and says that Johnny has fallen asleep repeatedly on the school bus or in class or when we get home after dinner. Typically, it's the opposite. So the main presentation is often the opposite of what it is for our adult population. So this is a point of reference. So this tells us where we are in time. So this study, which was done in 1976 by essentially the Watson and Crick of sleep medicine, Dr. Guilleminault and Dr. Dement, identified that the syndrome of obstructive sleep apnea, as we knew it at the time in adults, seemed to be present in children. And they were right. This is the first description of it. It was 8 children. At the time, the treatment was very effective. 6 of them got a tonsillectomy. 1 of them got a tracheostomy, and 1 was lost to follow-up. But the interesting point, that function of a point in time, is that 1976 was not that long ago. So when we look at the breadth of healthcare and medicine and the management of all disease entities, it spans back for hundreds of years. We're going back 40 years in time. The obvious point is that I wasn't born at the time the study came out. That was close. I was getting there. So epidemiology-wise, we talked a little bit about the problems that impact kids in presentation. Now this is actually who has it, and it's a very large proportion of the pediatric population. So at least 10% of young kids are going to snore. There's going to be a large handful of those are going to qualify for obstructive sleep apnea syndrome. And then the other somewhat forgotten about entities, the obstructive hypoventilation and the upper airway resistance syndrome, account for another handful of percent. So all comers to the pediatric clinic, or whichever clinic you may be seeing the patient in, can probably be tailored to a lot of those people with complaints do have an underlying medical condition that should be addressed. So in my mind, in terms of the font size that I use, history is the most important. Physical exam then supports what your history is and narrows your diagnostic, what your working diagnosis list is. And then the objective testing measure comes in only after you have defined or pointed yourself down the pathway towards what you think you're going to find. I'll define actigraphy just in case there's some people that aren't familiar with it, but it is essentially a wristwatch evaluation that's worn for a period of about 2 weeks, and it measures light and it measures activity. And so it is incredibly useful for the evaluation of the patient where you're not suspicious of an underlying organic problem, a structural lesion, but you're more concerned that this person just isn't sleeping enough, or the patterns are off. And so when you use that in connection with the sleep diary, you can give an amazing amount of feedback back to the family. And this applies to adults also, in terms of this is what you think the sleep patterns, total sleep times are, and this is objectively with the good assessment of where we think things actually are. And then we'll go over some of the laboratory and some of the other studies that are used that don't play a major role, although they can be supportive. So this is a really interesting study that looked at it was a group of 100 children, and they all had pretty severe sleep apnea. The mean AHI was in the range of 15 with SATs that ranged down into the low 70s. And they were looking for what the correlation was in terms of presentation on a clinical evaluation. And the notable here is less than 10% of these kids actually had any form of complaint of being tired. So sleepiness is rarely going to be the presentation that you're going to get. The one other notable here is that of those 7.5% that were sleepy, almost every single one of them was significantly obese. So in that population, the people that are going to complain of sleepiness are going to be the ones that already have that higher pretest probability just on their appearance when they come into the clinic. And we'll talk again more when we get to the clinical evaluation portion of it. But the notable here is the children that are more likely to have a severe form of sleep apnea, those are the ones that are likely going to say, I'm sleepy. Or the parent's going to report to you they fall asleep repetitively and unintentionally throughout the day. So on your evaluation, when you're looking for parent-reported symptoms, there's going to be the daytime and then the nighttime problems. And I'm going to highlight here as I skip through a couple of slides in the following order of which ones are going to be the most specific to the presence of some form of sleep disorder breathing. And that's the witnessed apneas, has the highest correlation with actual findings of obstructive sleep apnea on a sleep study, followed by paradoxing, which makes sense because that's going to be the next visualization if your upper airway is closed and you're working against a closed glottis, to mouth breathing, which is going to be a form of bypassing an area of obstruction in the upper airway. And so those are going to be the three main things that will be reported from a nighttime standpoint. And then during the day, again, like we had talked about, since rarely is the behavioral complication going to be sleepiness, usually it's irritability, behavioral problems, attention deficits. And so that's what the parents are going to complain is he's doing terrible in school, he's snoring, this has been a progressive problem. What do you think it could be? And then lastly, the people who do complain of excessive daytime somnolence should raise a little bit of a red flag in the back of your mind when you're talking to them and say that I would want to have a more invasive or a more in-depth evaluation because the likelihood of sleep disorder breathing in these kids is going to be higher. So in grown-ups, it's pretty straightforward. It is an Epworth Sleepiness Score and a stop bang evaluation, both of which can be done in a handful of minutes that have good validity in correlating who is likely to have sleep apnea on some form of objective testing. In kids, we do not have those measures. Neither of them can be used in the pediatric population. These two are both great questionnaires. The problem is they're incredibly long. The pediatric sleep questionnaire is 67 questions, and the children's sleep habits questionnaire is, I think it's 45 or 47. So the actual utility of using these in the office during a 20 or 30-minute evaluation is pretty limited. But within these, and particularly within the pediatric sleep questionnaire, there is a sleep-related breathing disorder subscale. And this is more consistent with what we use for our adult patients. There's 22 questions in a simple yes, no, I don't know format. And the nice thing about that is it actually is feasible to be used in a busy clinical setting, and it is validated and correlates very well with the presence of obstructive sleep apnea. So the parent would yes, no, don't know, yes, no throughout this list of 22 items. You exclude the don't knows, and then you take the yeses divided by the yes plus the no's, and if you come up with a percentage of 0.33 or 33% or greater, the likelihood that you're going to find sleep apnea on a sleep study is pretty good. And so it's one that can actually be practically used, and it's the one that I use in my clinic when I'm screening kids. So now shifting to the clinical examination portion of things, it's mostly normal. And so that's another major limitation on when you're doing your office-based evaluation. So the easiest screening modality is going to be to look at the child, what the habitus is, and then follow it up with looking in the back of the airway to get an assessment of both the size, the patency, and make an estimation of what the collapsibility may be. So tonsillar size is the most commonly reported referral documentation that I have for kids in the clinic. The problem is that it doesn't correlate very well with the actual presence. So aside from the size of the tonsils, there's actually quite a few things we want to be looking for during your clinical evaluation. The mucous membranes in the nose, and so these are all again going to be things that need to be applicable in the clinic so you can make an assessment during either a brief office visit or a busy clinic day. So the appearance of the faces, obvious septal deviation, which Dr. List had referred to earlier on in his talk yesterday, high arched palate, buck teeth or the overjet, notable retrognathia or that recessed jaw, mid-face hypoplasia. So some of the more obvious things that will be clear upon early presentation. And then if you look down at the bottom of the list, it had talked about the cardiovascular complications in the extremities. So if there is a child who has diastolic hypertension or any form of hypertension, notably loud P2 on your evaluation, or rarely it would be seen as clubbing, but if they have lower extremity edema, those are going to be more very concerning signs that should really kind of pique your curiosity for a more broad evaluation, because that is evidence of systemic manifestations of obstructive sleep apnea. So once we have gotten to that point, it's very important we focus on the how did we get there? What could have caused these clinical findings? So this is a great article. It's a couple years old, but it's still pertinent today because we still perform our history and physical exam in the same manner. And so Scott Bretsky is an otolaryngologist who practices at Naval Medical Center, still active duty. He's written lots of literature, and this is a really interesting retrospective review that he did, because if you look at the sensitivities and the specificities, and there is some outlier data in here, but the general trend is that we have high sensitivity. In other words, it's very, very likely that people with sleep apnea are going to manifest those symptoms, but fairly low specificity. So that physical exam finding leading us to a specific diagnosis is significantly less likely. And the one that I find to be the most notable is the tonsillar size down there at the bottom. 3 to 4 plus tonsils, those are big tonsils. I mean, that is not easy to miss during an office evaluation with, all you need is a pen light and something to move the tongue out of the way. But the specificity of that finding is actually fairly low. And so what that then raises the question of is, we have a very sensitive clinical evaluation with low specificity. Does it lead to a false positive presumed diagnosis? And then subsequent to that, either an unnecessary procedure or something that maybe isn't going to fix what the primary problem is or what the parental complaint is. So a couple minutes talking about the pathophysiology. Any form of sleep disorder breathing is going to be on a spectrum of airflow resistance. So snoring, you're still moving air, but the noise is made because now flow is turbulent. You have a partial airway collapse, and you get an acoustic manifestation of that problem. All the way down to the obstructive events, which are very visibly apparent, lots of work of breathing involved, but they don't make any noise until the end or the termination of that apneic event. And then in between those two, we have the obstructive hypoventilations. And I want to point out a couple of the details about obstructive hypoventilation, because I think that is one of the things that is more likely to be missed on a polysomnogram for a kid, because it does not have the typical frank apneas, elevated end-tidal CO2 levels, apneas or hypopneas that we're trained. I mean, a lot of what we do interpreting sleep studies and reading them is pattern recognition, right? And so if we don't see those clear patterns, then the likelihood that we identify that problem is going to be a little bit lower. Primary snoring we talked about, obstructive hypoventilation again, respiratory events stay normal, but it is our end-tidal CO2 levels which are elevated throughout the study, and that is reflective of the poor ventilatory process. So usually these kids do not have persistent or even notable hypoxemia, but they have either large peaks in their end-tidal CO2 levels, or they have consistently sustained levels of end-tidal CO2 throughout the study. So it's really, really important that in reviewing labs or in reviewing studies that you've obtained, that is a component of the evaluation, or that you ask for that up front to ensure that it's a part of the sleep study that's performed. And then obstructive sleep apnea has very clearly defined respiratory events that are scorable, and we're guided by the American Academy of Sleep Medicine scoring manual. So that is a little bit more clear, but that pattern recognition again is going to be more obvious to us. So it's the other two that do have inherent morbidity that we don't want to miss. So I think this sagittal view, this cartoon has come up, 30 times or so in the last couple of days. And as Dr. Listed pointed out, it really is truly amazing when you reference it in the context that he did, and that portion, the pharyngeal airspace that we are interested in, is a very small component of the body. It's a couple of centimeters, small diameter, but the implications it has on essentially every other body system is pretty notable. So I think it's worth reviewing exactly what that is and how it works. So of that, do we have the flashlight? Here we go. So the pharyngeal airspace is going to be the zone right in here. It's going to extend from the end of the nasal choani, so where the soft palate originates, and it's going to come down until you get to the epiglottis region, so above where your larynx is. So this zone right here is where all the problems arise. Now when you think about that structure, it's just a floppy tube, right? And there is a single point of anchorage on there, which is going to be the posterior pharyngeal wall. So that's where you're going to have the bony support structures that are going to be sitting back over here. So the rest of it, the other three sides of the circumferential structure, is just muscle. And what's pretty amazing about that muscular space is that it is incredibly dependent upon your state, whether you're awake or you're asleep, the levels of CO2 and oxygen, so whether you're hypo, U, or hypercarbic, whether you're hypoxic or not. And then the last thing is going to be negative inspiratory pressure. So there are negative pressure receptors in the larynx, is where they're primarily clustered, so that every time we take a breath in, those dilator muscles, which are going to be your palatal muscle structures, the genioglossus, and then all of your hyoid muscle structures here, those are going to become activated. And so you get a reflexive response to dilate and to stiffen that muscular wall to keep it open, which is consistent with life, right? Because if every time we try and take a breath we collapse, there's going to be problems that ensue. So the other thing that is interesting about this airspace is that the medications that are going to affect it, things that we typically use, pain medications, anesthetics, the size of the individual, airway edema, are also going to play an impact on the patency of that airspace. So a concept that is probably worth touching base on is what's called the critical closing pressure. Because all we're trying to do in all of our approaches therapeutically that we do is just to keep this airway open. Like Dr. List said, for him it's easy just to cut it out, open it right up. Not everybody is going to want that approach, or nor does everybody need that approach, but it certainly can be effective. The other options then, do we just splint it open with air pressure, a CPAP machine, or some form of, or do we mechanically splint it by adjusting where the position of your mandible is over there? Each one of those essentially is just opening up that airspace. The collapsibility of it is dependent on something called the critical closing pressure, the P-crit. And the P-crit is, you see over here as we work down our way into the different normal, slightly abnormal, and then grossly abnormal, is going to be the pressure at which that airspace is actually going to collapse. So this critical airway closing pressure always needs to be more negative than atmospheric pressure. In grown-ups and in kids, the number is about negative 10 centimeters. So if we think of this zone, which is far more complicated than this cartoon relates to, but if we look at it in this cartoon format as a Starling resistor, we have the upstream segment, which is the bony area of the upper airway, or cartilaginous support. The lower segment is going to be the cartilaginous rings of our trachea, and in between, that's going to be the collapsible zone, right? So if we take our critical closing pressure and we keep it more negative than the downstream and the upstream segment, when we pull air through, and air is pulled through by a function of pulling negative intrathoracic pressure to bring lung from the atmosphere down into our airway, then we're fine. There's no issue. But as that critical closing pressure gradually becomes less negative or more positive relative to the downstream or the upstream segment, this is where we get into the zone of collapse. And so part of our evaluation should be to understand why that is happening. And so that's again why the architecture, that physical exam, although not necessarily the most specific, is critical to tell us exactly what could be contributing. Medications, where our history comes into play. What's this person taking? What's this child taking that could be contributing? And then of course, is there any type of ongoing injury? Allergic rhinitis, chronic edema, that could be swelling it and decreasing either the pliability or the activity of those dilator muscles. So I think it's a pretty good concept to review because it really kind of puts into perspective the simple zone that has a very complicated both process to diagnose and then to treat. So now making a diagnosis. So we've got the history, we've got the physical examination. We're going to in a couple minutes talk about the actual numbers we use to figure this stuff out. The clinical history takes that forest and it narrows it down to a couple of trees, so you know what you're looking for. The physical exam then is going to help us support what we thought was going on up front, but it's rarely going to be good enough to utilize to say this is no question, this is a slam dunk case of obstructive sleep apnea, or this is just primary snoring, we should perform some watchful waiting. So the next objective measures that are, again, rarely used is MR, cephalometry, laryngoscopy, lab studies, echocardiograms. And the problem is none of these are going to be confirmatory. So they can absolutely be supportive of what you think is going on, but then to guide what your management is going to be in and of itself is going to be pretty limited. So what we want to know is, Do we need to get an echo because we suspect severe right heart failure given the severity of the sleep apnea? Might be good to get for some kids, but it also needs to be in conjunction with the confirmatory test. So then can we just listen to them? And I'll see if I can't. And I can only imagine, are there any pediatricians here today? Any family practice physicians? So how many times have you guys ever had somebody bring you an iPhone video of the patient snoring, right? And say, does this work? Can I get a CPAP machine? Or can I go see a surgeon as a result? And oops, I don't know if my video is going to play. Well, there's not much of a punchline here. This is a kid that snores. But this is often what you're going to get. Oh, I'm sorry, guys. This was done with the Macintosh. No. So if you could imagine, with the video in the background, you've got the picture, right? So the sensitivity of this is through the roof, right? Because the majority, the large majority of people that have sleep apnea, kids especially, are going to snore. This is a group out of Mount Sinai that then looked at this in a series of, well, how well does it correlate with either polysomnographic findings or validated in-office questionnaires? The answer is very, very poorly. So again, highly sensitive, fairly low specificity, so not good in and of itself as a diagnostic measure. So then we skip forward to PSG testing. Clearly the gold standard, but that does not mean that it's the best, because there are going to be several inherent limitations in use of this study. There are multiple practice guidelines that have all come out in the past couple of years that support use of polysomnography. It probably won't come as any surprise to anybody that the American Academy of Sleep Medicine says for the pediatric population, if you suspect it, everybody should be studied, right? If you're a hammer, the world's a nail. The American Academy of Otolaryngologists is probably the most conservative in their use of their guideline approach. And what they say is if you suspect it, it needs to then be further supported by craniofacial abnormalities, somebody who's a severely obese child, you have a history of a neuromuscular disorder, you have a metabolic problem, or you just have no idea. There's a major discrepancy between the referral question and your examination. The history of daytime manifestations does not fit with what you see clinically. And in those cases, they say that you really need to get the most evidence that you can to support what you're then going to do. And then the American Academy of Pediatrics falls somewhere in between, but sides much more closely with the American Academy of Sleep Medicine. So one of the nice things about sleep studies is that although we don't have great data to support the ranges that we use for diagnosing, which we'll talk about in a few minutes, we have very clear standardization amongst labs everywhere in the country that should be using the same scoring criteria. And that is extremely beneficial when we've just looked at some of the other modalities that are used that might have poor standardization, test to test, or lots of inter-rater variability. So it's probably worth going through these real quick. Similar to adult criteria with several different components. The big one is going to be the duration of the event. So in kids, it's going to be a 2-breath duration for a scorable respiratory event. And that 2-breath comes from, so in adults, it's typically 10 seconds, right? And 10 seconds comes from the respiratory rate during sleep is usually 10 to 12 breaths per minute. And so if we then divide that by 60 seconds, we're going to get 1 breath about every 5 seconds for a grown-up. And so this is the correlation that we use for children. And then for a hypopnea, you've got to have a clear fall in your nasal pressure amplitude by 30% for those 2 breaths, associated with the desaturation of 3%, or an arousal. And that or arousal part is important because when we look at bullet point number 2 on this slide, the RERAs now for children is an incredibly wide presentation of things that you can see on a sleep study. So we're going to come to that in just a second. But then the central apnea is going to be events that are long. So they do specify it can be at least 2 breaths in duration, but the younger the child, the more physiologically normal the presence of central apneas are going to be. And so one of the things that needs to be looked at and needs to be discussed with the referring provider is when you get these respiratory indexes, RDI, AHI, in a pediatric patient, you need to clarify what the true obstructive index is in these individuals. In other words, if you have a result that says there was an RDI of 1.80, which would be consistent with mild obstructive sleep apnea for a pediatric patient, but 0.8 of those events were central in nature, and on further review by the interpreting physician, you see that they were usually post an arousal or they were during transitional periods of sleep and are of unknown clinical significance, then what you're left with is an obstructive index, which is now almost normal. And if that is missed, the typical therapies that we provide for patients are to resolve obstruction, right? And so if we're now pursuing an index which is essentially normal, once you remove that central component to it, are our therapies for obstructive sleep apnea going to provide much clinical benefit? I think that's a big question. So then to move back into the RERA category, this is actually a really interesting study done by a group in Louisville. And what they were actually looking for was either a score that could be utilized for children to determine sleep apnea, and they were looking for architectural changes that occurred during sleep. And there were some really notable findings that came out of this. One was that kids rarely have the amount of fragmentation or disruption of sleep architecture that grown-ups do. They essentially maintain slow wave sleep with or without sleep apnea, and they maintain REM sleep with a lot lesser degree of fragmentation than we see in adults. And the two, I think, the most interesting points here is that when you look at cortical arousals, so the EEG changes that we track for an event that was either spontaneous, so nothing happened, it just changed, or it was precipitated by a limb movement or more often a respiratory event, very rarely in kids, 1 of every 2 events is actually associated with some preceding respiratory obstruction. And during evaluations in kids who have obstructive sleep apnea, the more severe, the lesser the degree of the actual arousal index, which suggests that these kids actually don't manifest cortical symptoms of obstructive sleep apnea like adults do. So then if we take a step back and we say, well, how do we score sleep apnea in adults? Or how do we score RERAs in adults? Well, it's going to be some form of EEG change that we say is associated with the PTAF flattening or increased respiratory effort, but there's a pretty clear association that we utilize. If we apply that same criteria to kids, we're now using these arousals, which we just have described as being less common in kids. So the concern is, are these arousals either completely spontaneous or are they not pathologic? Is it movement? Is there environmental changes in the lab? Was it something else that precipitated it that wasn't an obstructive respiratory event? And I think that's important because in grown-ups, we can apply normative databases to use of the RDI criteria. In children, normative data for the presence and the frequency of respiratory effort-related arousals, it's a mouthful of a word, is very scant. And so if we're reporting high RDI indexes with normal AHI indexes, again, the concern would be that we're leading to a false positive diagnosis, which then may lead to unnecessary or not beneficial therapies. So I think it's worth then looking at some of the normative data that we do have for children. And what's really clear here is they're low, right? So our obstructive, our hypopneas, and our central indexes are near none. And so when we look at these diagnostic categories for pediatric sleep studies, you know, we start rolling in at 1.1, 1.2, 2.1, and that probably is significant, again, if the events are supported, but for the most part, kids shouldn't have obstructive events during sleep. Normal should be almost no respiratory occlusion. And then if we look at what our oxygen level should be, this is another notable, is it should be normal. And if we look at 2 standard deviations above or below, most children should not desat below 96, 97% throughout the duration of the study. So if you have a study that looks borderline normal, your RDI or your AHI is around 2, and it doesn't look that bad, and your clinical examination was not that remarkable, but you see persistently low O2, 91%, which doesn't sound that alarming, for a child, that is significantly abnormal. And then the last thing is to point out what our arousal index is here in children, and it's very low. Probably around 5 or 6 arousals per hour is what you should expect for a normal kid. These are spontaneous, not associated with any form of a respiratory event. So then, as we get towards the end of things here, we look at what we use for our scoring criteria. This big block right here, if we cut off this group over here, I consider to be the gray area. And the clinical evaluation, the history, the physical, the parental, and or the patient complaint must be used to sway you into pursuing therapy for these children with mild obstructive sleep apnea. There's, in my mind, almost zero question about what to do with these guys. Tonsillectomy, without question, remains the recommended and the correct first-line therapeutic approach for children with moderate and severe obstructive sleep apnea. The ones that are less clear are going to be the group over here who have snoring, minor daytime symptoms, and a mildly elevated RDI. And my concern would be that they are reflexively referred for either a CPAP machine, if the parents say, no way, in my mind, am I going to consider surgery, or they go directly to surgery without good support that that's going to change what led them to come to see you in the first place. So I think one of my favorite quotes is one that I got from a sleep conference 2 years ago, and it's from Dr. Peruthi. And what she said was, to score is different than to interpret. And I think that's what is fundamentally required out of sleep practitioners, is that putting a number on a report is pretty easy. You look at the numbers, you add them up, and you come up with indexes, and then that's what all of our reports generate. But then to provide an interpretation on top of that number, that is what is critically important. Because the context, right, the picture of what came to you in the first place, the AHI, flow limitations that were observed, what the SATs did, what the end-tidal CO2 monitoring did, work of breathing that was reported to you by the technician staff, how often this child had movements during sleep that were associated with small obstructive events. That actually forms your clinical pictures. Then you can make a very well-guided decision to help tell the parents what you think the next best step should be. So I think that's if you forget everything throughout this presentation, I think really that the interpretation, which needs to encompass the whole clinical evaluation, is far more important than the number that ends up on that study report itself. So it's pretty close to the end, and I think we just covered these last couple of bullet points here. So I think I'll open it up. I know I myself am the only thing right now that stands between you and a really nice afternoon out there. So any questions or concerns about the topics here? Please.
I have a question. First of all, I love how you call it adult scrums.
Big people.
But, and you're right that ours have left floundering having to put them poorly. Mm-hmm. Whether it's this or imaging, whatever it is. But I found little bits of literature. I don't work with kids at all, but I do have patients with sleep disorders like narcolepsy without cataplexy, and I find these viral clusters that really are reactivation of childhood viruses like EBV, cytomegalovirus, carbon-19, and I'm wondering, since you're in the pediatric literature, if you have seen any kind, any researcher or anything, anybody looking at this, because it's, I have seen it over and over again.
Sure. No, so it's probably best described by the recurrent hypersomnias, the Klein-Levine syndrome, is that is probably preceded by some type of a viral prodrome. Now, specifically identifying the type of virus or what the actual inciting event was is a lot less clear. But one of the guys I had trained with was a pulmonologist down in Wilford Hall Medical Center at Lackland. And he was convinced that the majority of recurrent hypersomnias, these unclear, no identified etiology, so that they don't have sleep apnea, they're not insomniacs, they have decent total sleep time. This was in adults, was the discussion, that he was convinced are related to some form of an immune insult, so some type of viral syndrome. The problem is then either quantifying or qualifying that. So how do you prove that? Because then you go back and you look at immunoglobulin levels, and you look at whether it was a recent or a distant insult that you had, and it's hard to put the pieces together. But that was his best guess, was that without question. But I think when you look at the literature and you determine what is supported by the evidence, there's a paucity of stuff that says that this causes that from the hypersomnia syndromes.
So if I email you, would you email me this?
Sure. Yeah. After we get done, I'll just come drop my email down for you. Sure.
I don't treat any kids. As a psychiatrist, I see a lot of adults with ADD.
Yeah.
And I'm just curious, when you look at kids who have a primary suspicion of or diagnosis of ADD, do you have any sense of what percentage of them wind up having an underlying sleep disorder?
So that's an excellent question. So the ranges of association that's been assumed goes from anywhere from 10% to 90%, and that's specific to undiagnosed sleep disorder breathing and the presence of some attention deficit disorder, whichever form it may take. What's been really frustrating is actually proving that connection between the two. One of the, I think, more interesting studies that was done was the CHAT trial, which was recently done, and it was looking at the impact of tonsillectomy on all sorts of neurocognitive assessments, quality of life measures. And the outcome was actually kind of surprising in terms of the reduction in these neurocognitive and neurofunctional testing. It didn't show that much improvement. I think there were several reasons why. I think that the population they used was older than the people that benefit primarily from a tonsillectomy. But what they did show was that the quality of life metrics and patient satisfaction, parental satisfaction, and reported behavioral disturbances, which is really hard to tie an objective measure onto, all without question improved dramatically post-tonsillectomy. And that was in the arm of patients that had a tonsillectomy, whether they had mild, moderate, or severe sleep apnea. That showed benefit. And so, my best guess, because that's what it is that there is a clear relationship between those two processes. And I think that early identification is really important, because what you want to do is, you may not be able to solve the problem, but if you can take out confounders or uncomplicate it as much as possible before a child is referred to a behavioral psychologist or behavioral psychiatrist, then I think you've done them lots of good and potentially avoided lots of unnecessary medical therapies. That answer your question somewhat? Dr. Glass.
So if you're a pediatrician or a primary care doc, what is it that triggers you to say, I need to send this person in for a sleep evaluation? If they do have an attention deficit type symptoms, do they need to snore, do they need to kick around a lot during night, do they need to have assessment? What is the sort of fast and dirty rule as a primary care doc with kind of not that much time sometimes to say, I need to pull the trigger on things?
Yeah, and I think that was why I included that sleep-related breathing disorder questionnaire, because it's the only, what I think, and Dr. Glass made a good point, feasible, right? Has to be clinically usable, or it's not going to get done. If you ask somebody to do a 67-point questionnaire, you're never going to see one come across your office. So I think that a combination of that questionnaire, which is a 22-point assessment, which is valid when compared with using a polysomnograph assessment, in addition with the clinical history and a physical exam, which is supportive. Now, I know that sounds somewhat contradictory because we said that it's good, but it's limited, but that still is what our primary tool is, right? In the fight against whatever disease is coming to us, we look at it, we hear what it is about at home, and then we make an assessment on what it is most likely to be. And I think that there is still going to be a fair number of patients which, if there's no clinical suspicion and that everybody, like there's 4+ tonsils, witnessed apneas, we did a pulse ox monitor and there were repetitive prolonged periods of hypoxemia, I don't know if a PSG is truly going to change diagnosis at all. But what I do think it will do is change the way you approach it clinically in the operating room, and then what you should do for that child after they've had the intervention. In other words, I would hate to miss the child who has oxygen nadir of 64%, that postoperatively has a complication that could have been clearly defined with the polysomnograph early on, so that that conversation with the sleep doc or the pediatrician, the surgeon, and the anesthesia team all could have been had preoperatively. And that's also the group where I think that the management changes, because those are the kids that I want to have proven resolution of their obstructive sleep apnea, 2-3 months postoperatively, so we can say that it wasn't, or we can say that it simply was an anatomic obstructive problem, not more of a complex, well, actually this is more of a pharyngeal collapse issue that wasn't only the tonsils, it was the tonsils plus this. So I mean, that's in short for your question. I think with the SRBD questionnaire and with the highly supportive physical exam and a history, I think within 5 minutes you can make your pretty good litmus test on who does need to be referred for a sleep study. Sir.
Just to add, as a dentist, I know that to take care of the tonsil adenoid issues before the growth spurt, you can actually have positive bacterial and medical development in the airway at that age. So if you do see someone with, grade 4 tonsils and they're having sleep problems, and you get them to an ENT, you can develop you can have a symptom and develop of your maxilla.
Yeah, you're like a plant in the audience for me. Because like we were talking about earlier on, is one of the things is that the metabolic, the growth, the behavioral development of kids is just happening so quick at the younger ages. And so if you can address this issue early on, you could potentially avoid all sorts of complications. So I agree with you entirely. Ma'am? No, it's a. Yeah, if I may, I'll rephrase the question a little bit. Yeah. Yeah. So the question, which is a very good one, and also which was addressed in the chat trial, was, I mean, there's no way that it's possible to get a sleep study on every child who's going to be referred for a tonsillectomy. The resources just aren't available. So the question is, what do you do with the children who you suspect may have an adverse postoperative or perioperative complication, when you do not have access to a sleep study or the financial resources to get a sleep study? Does every single one of those kids need to be admitted to the hospital? And the numbers are pretty impressive. There were 530,000 tonsillectomies were performed last year, which is actually a dramatic decrease from several years prior. But the authors of the chat trial were clear in that that is a resource which is not readily available to everybody. So what you do then essentially is going to be the best you have with the judgment and the resources that are available to you. So what I mean by that is knowing that tonsillar hypertrophy with witnessed events and recorded hypoxemia, or a clear history of recurrent repetitive obstructive events at night by the parents, that's causing a problem now. And so to defer that for 6, 7, 8 weeks while you wait for either a polysomnograph or access to home pulse oximetry study probably isn't the best route for the patient. So that's where that communication between the surgeon, the anesthesiology team and then the family is going to be that we don't know for sure, but this is an individual who we think needs to be monitored for at least 24 hours after the hospitalization. And then whether the home care involves some form of supportive therapy, CPAP for a period of time afterwards, empirically used to prevent that airway collapse while they might be on narcotic or pain medication, or an apnea monitor, so you're able to have a recorded event monitor which will tell you whether you're having these hypoxic events that can alert the parents during sleep, may be your best option, simply because of the availability of the resource of an in-lab study for everybody. Yeah. Well, I think that then that falls into, again, you have to take it on a case-by-case basis. I mean, if there's post-operatively within that 12-hour period, if they're doing well, because there's going to be a period where you can probably either observe them with an anesthetic or a pain medication on board or during sleep. And if there is, no clear problem during that window, it's probably safe, but if your clinical concern is high enough, then I think that's really where those hypoxic monitors need to go home with the children. And then if you do see a problem there, I think the onus is really to extend that hospitalization time until you know for sure that severe apneic event or the removal of the anesthetic or the pain medication is not going to be a complicating factor. It's a good question.
I just want to echo that because the FDA letter that went out a year or so ago were on 3 children who post-tonsillectomy died.
Yeah.
And they got codeine and they were ultra rapid metabolizers, and this resulted in the death of these 3 children.
Yeah.
So we really need to be cautious about this particular issue. And I also pointed out the fact that because of the paradigm that they are REM deprived in the hospital, they go home, and the next 2 or 3 nights they get a lot of REM sleep, and if they are on these medications, this could be potentially a very dangerous situation. So in the absence of not knowing they have sleep apnea or not, because if they do, with the surgery and the medication, this is going to get worse. They got to be extremely careful.
Absolutely.
And the other thing I wanted to mention, I know you quoted a couple of studies of David Gozal. Actually, in terms of the question that was asked, what David showed was that post-tonsillectomy, in a number of these children, they still had a significant amount of sleep apnea. So when you think about whether you should do a sleep study before tonsillectomy or after tonsillectomy, really the question arises that it is the post-tonsillectomy thing that, especially if the children are obese, the study probably should be repeated to make sure the sleep apnea has been eliminated.
Oh, I entirely agree. Yeah, and so the Academy of Pediatrics and the Academy of Sleep Medicine are clear on that recommendation. And then the Academy of Otolaryngologists gives a lot more discretion per the provider. But I feel pretty strongly if 6 or 7 weeks afterwards, if there hasn't been a dramatic resolution of what the presenting complaint was, then you need to prove that it's not still related to what the problem you thought you were treated was.
One more comment that there is another investigator in the pediatric age group, Dr. Amin, who has done extensive work on cardiovascular disease in children. And one of the important things that has come up with his work, he's at the University of Cincinnati Children's Hospital, is that a lot of these children with obstructive sleep apnea could suffer from diastolic dysfunction. So if there is an echo at one point in time available for whatever reason in these children and they have diastolic dysfunction, they probably should suspect the presence of obstructive sleep apnea.
Yeah.
Finally, there is data in children with valvular disease or congenital heart disease that they also may suffer from significant amount of sleep apnea, perhaps even central sleep apnea. So that's another category that may be important.
Yeah, and again, this clinical investigation is so young in relationship to not just the field of sleep medicine, but the field of medicine in general, that I think that we will probably learn tremendous amounts of information just in the next couple of years, which hopefully will improve both our referral and treatment options, but just what we need to be doing is, clinical outcomes, making patients better and safer. Any more questions? Okay, I think that's it.